Okay, let's talk a little bit about the physiology-related exercise for this case. We have a separate vignette for this. It just made it easier for me to get my point across. We have Ray Wilkins. He's a 58-year-old man with hypertension, and he's on hydrochlorothiazide, and he's got signs of hypercalcemia, and his blood work shows hypercalcemia. So you take him off of the thiazide diuretic and you put him on amlodipine, and he comes back and you expect him to be better, and he's not. And in fact, you repeat his blood work and his serum calcium is still elevated despite being off of the thiazide diuretic. So that wasn't what was causing his hypercalcemia. So it's up to us to decide what was causing his hypercalcemia. So let's take a look at his blood work. And here it is. And what you see is, first of all, the calcium still high, right? Above 10.7. And look at his PTH. Very high. You know, about double normal. So high PTH and high calcium. So this is kind of a puzzle, because if you look at what PTH is supposed to do when plasma calcium gets high, plasma calcium should be decreasing PTH secretion so that you have low PTH when you have high serum calcium. And that should make sense to you. PTH liberates calcium from bone and causes you to reabsorb calcium in the kidney, etc., etc. Its purpose is to raise calcium. So when plasma calcium is low, you secrete more PTH in order to bring it back up toward normal. When serum calcium is high, you should be secreting less PTH, because you want to do the opposite. You want to stop liberating calcium from bone, and you want to urinate more calcium and get rid of it. So this is inappropriate secretion of PTH. And another way of saying that is it's primary hyperparathyroidism. Whenever you see high calcium and high PTH, you should be thinking primary hyperparathyroidism, that is inappropriate PTH secretion that is causing calcium to be high. If the PTH is high and the serum calcium is low, that is secondary hyperparathyroidism, and that would usually be due to the fact that something else is causing plasma calcium to decrease, and PTH has increased in response to that in an effort to bring calcium back toward normal. So that is secondary hyperparathyroidism. Primary hyperparathyroidism, high PTH and high calcium, that's what you should be thinking. You should be headed in that direction when you see those two things together. Okay? So, our mission is to explain the abnormal values in that test. So we have high calcium, and I think I just explained that. You have high PTH, and that is causing lysis of bone and increased calcium absorption from the GI tract through vitamin D. We'll go through that in a second. It's causing calcium to be retained in the kidneys, and your serum calcium is inappropriately high. The next question is, what do we think will happen with phosphate? Well, our PTH is high. The question is, what does PTH do to phosphate? PTH causes in the distal convoluted tubule calcium reabsorption, more calcium reabsorption. In the proximal convoluted tubule at the same time, it causes less phosphate reabsorption. In other words, it causes more phosphate to be excreted in the urine. So you are losing phosphate in the urine. You would anticipate that phosphate would be low, which of course it was due to the fact that PTH is high. Alkaline phosphatase, what should be happening there? Well, we think alkaline phosphatase. Which alkaline phosphatase have we talked about? We've talked about TNAP, tissue non-specific alkaline phosphatase. TNAP is high. When TNAP is high, you are hydrolyzing pyrophosphate into inorganic phosphate. And we know pyrophosphate inhibits calcium inhibits bone formation. So if you hydrolyze it, that stimulates bone formation. So high TNAP means high bone formation. So wait a second. Shouldn't high bone formation cause you to be storing more calcium in the bone? Shouldn't that decrease plasma calcium? Well, you would think that. The ordinary person would think that, but you are a medical student. You are not allowed to have common sense, and you're not allowed to be an ordinary person. It turns out that, in fact, when you have high bone breakdown through high activity through osteoclasts, you also have high bone formation through stimulation of osteoblasts. Remember this chart. When, in order to get high osteoclastic activity, you have to increase osteoblastic activity. And in fact, that's what PTH does directly. It directly increases osteoblastic activity, and that increases the secretion of MCSF and RANK-L, and that stimulates this side of the equation and causes more osteoclastic activity. So you are increasing osteoclastic activity, yes, but at the same time you're also increasing osteoblastic activity. You're just increasing osteoclastic activity more with high PTH. So yes, high alkaline phosphatase means more bone formation, but because you're getting both more bone formation and more breakdown, when you stimulate bone breakdown with PTH, high alkaline phosphatase activity is an indication that you are actually breaking down more bone, okay? So high PTH stimulates osteoblasts, that stimulates the osteoclasts, and you get more osteoclastic stimulation than osteoblastic stimulation. That causes more bone breakdown. At the same time, you get more bone turnover. And because there's more bone turnover, that is more formation, at the same time you're getting more breakdown, you get high alkaline phosphatase activity. So we would anticipate alkaline phosphatase would be elevated, and it is, all right? So, 25-hydroxy vitamin D. So what would PTH be doing to vitamin D? Well, we know that it stimulates 1-alpha-hydroxylase in the kidney so that you get more conversion of 25-hydroxy vitamin D to the active form 125-hydroxy vitamin D. And so if you were to guess what the effect of high PTH would be, you would guess that 25-hydroxy would go down and 125 would go up because you're stimulating this enzyme, okay? And in fact, that is what happens. 25-hydroxy goes down because you're forming more 125, and 125 goes up because you've stimulated that enzyme with PTH. 24-25 is sort of your waste form of vitamin D, and it really, if anything, it decreases because you're converting more of that 25-hydroxy to 125, okay? And so because you're diverting more into the 125 form, you would indicate maybe you might get less in the 24-25 form. This is sort of a form of vitamin D that's inactive. It allows excretion in the urine. It's sort of a way to bypass that 125 form. If you've got, 25-hydroxy that's constantly being fed in at a normal rate, you're either going to convert it to 24-25 or 125. And if you're converting more to 125, you might see an increase in a decrease in 24-25. I wouldn't say absent. If you look at the results, it's actually decreased. Not really absence per se, but you would expect it. You might reasonably expect it to be lower than normal. PTH is of course high because it is being inappropriately secreted by the parathyroid glands. All right, likely due to a parathyroid tumor. All right, good. Thank you for your attention. Good luck on your exam.